this video, we'll discuss about hyperthyroidism. So, it is a very commonly asked question and a very common condition that patients deal with on a regular basis. So, first of all, coming on to the definition. So, definition, it is a clinical state that is characterized by exposure of body tissues to high to excess of circulating free thyroid hormones. Body tissues to now just remember that in this the thyroid hormones will be increased. So coming on to the causes and causes, first of all I'll enlist the some of the common causes such as Graves disease, which we'll discuss further in the video, then multinodular goiter, then solitary nodule goiter, then we have uncommon causes like thyroiditis, drug induced, iodine induced. This is also called as George's based off phenomena. Then very rarely they can occur due to the pituitary or thyroid carcinoma. Now coming on to the clinical features. Now there is a very vast difference between the clinical features of the hyperthyroidism and the hypothyroidism. So first of all, I want you to remember certain things. In hyper, remember that there will be, since hyper means more, so opposite thing will happen. That is weight loss will happen. In hypo, which means less, it means that weight gain will happen. We are doing the opposite. Okay, we learn it in the opposite way. Okay, now coming on to the clinical features of hyperthyroidism. So first of all, we see goiter. It is diffused or nodular. Then in GIT, as I told, weight loss, diarrhea, vomiting, steatorrhea. Then in dermatological, we see perspiration is increased. Then there is clubbing of fingers. Then there is pretibial myxedema. This pretibial myxedema forms one of the components of the triads of the Graves disease. Then there will be loss of hair, redness of palms. Then in neuromuscular, what we will see is there will be muscular weakness, exaggerated tendon reflex, restlessness. All right, now coming on to the CVS part. So you will see tachycardia, and there will be good pulmonary volume, exertional dyspnea. Then in the reproductive system, we will have some problems such as in females, basically we will have menstrual irregularity, infertility, abortion. Then in ophthalmologic, we have staring look, wide palpebral fissures, exophthalmos, excessive watering of eyes, also diplopia. All right, now we have covered all. So one more thing, hyperthyroidism occurs mainly in females. Also, it is going to affect all the tissues that have thyroid receptors. Now we will discuss about Graves disease, which was one of the causes of hyperthyroidism. Now for Graves disease, I want you to remember there's a triad. You can remember this triad by PED. So first of all is pretibial myxedema. Then we have exophthalmos, and then we have the diffuse goiter. It is very common. It is the most common thyroid disorder. Now coming on to the etiopathogenesis, this is very easy to understand. So basically what happens is we have B cells and then we have plasma cells. Okay, now these plasma cells, they form antibodies that are immobilized that immobilize the antigen. Okay, now this, what happens is the immune system, it produces autoantibodies. Now these autoantibodies are called as thyroid stimulating immunoglobulins. Now they get attached to the thyroid cells. Okay, now these thyroid cells here, they start mimicking the action of TSH. Now what does TSH do? It stimulates the thyroid to release more of the thyroid hormones. Now due to this, there is an excess amount of release of thyroid hormones. So by this, if I ask you, thyroid hormones will be increased, but what we will see is TSH will be decreased because the function is being mimicked by TSI. Okay, and TSI will be increased. Now coming on to the clinical features, the symptoms and the signs. So in the symptoms, what we see is there is exposure of cornea, watery eyes, staring look, blurring of vision. Now here, most of the questions are asked according to the signs, so you must remember a few names of the signs. First of all, you can remember is the Joffro's sign. Now, in this, what happens is when the patient looks up towards the ceiling, there is an absence of wrinkles on the forehead. Okay. Also, then there is Mobius sign. Now, in Mobius sign, what we see is the patient is unable to converge the eyeballs. Then third is Dabby Rimple sign. Now, in Dabby Rimple sign, what we see is there is lid retraction. When the person retracts their lid, there is also the exposure of the or the visibility of the upper cornea. All right, then there is lid lag. Then there is diplopia, exposure keratitis. Also, if you move a finger across the eye, the patient will not be able to cope up with the movements of the finger. So basically it lags behind. Okay, so then osteoporosis, then you have pretibial myxedema. Now coming on to the investigations. In investigations, as I explained earlier, what we will see is we will see T3 and T4 is increased. TSH is low or it can be undetectable. Then there is the iodine uptake is increased. Serum cholesterol is low. In the echocardiograph, what you'll see is you'll see tachycardia, arrhythmia, so STT changes. Then ultrasound of the thyroid will show us diffuse goiter. Then we can to see this, we will do thyroid scan. Okay, now coming on to the treatment. Now first of all, what is the main objective of the treatment? First is that we need to manage the hyperthyroidism, management of hyperthyroidism. Now, this can be done in three ways. The first one is through drugs, the second one is through radiotherapy, and the third one is through surgery. Okay, now I'll discuss. First of all, drugs. The antithyroid drugs are indicated in patients who are either they are young or they are having thyrotoxicosis due to pregnancy. Thyrotoxicosis due to pregnancy, or they are having thyrotoxicosis plus small goiter. Now they're contraindicated in hypersensitivity reaction, where the patient is hypersensitive to certain drugs. Also in pregnant or in lactating women, in lactating mothers. Okay. Now coming on to what are the drugs. Now to remember the drug, I want you to remember PC. So basically you have propyl thiouracil as well as you have carbimazole. So in carbimazole, this is the drug of choice. Now, initially for 0 to 3 weeks, you will give them 15 to 20 milligrams 8 hourly. Now, why are we giving this? We are giving this to overcome the hyperthyroidism. Then after this, in 4 to 8 weeks, we will decrease it to 10 milligram 8 hourly. Now, this is being given to give to have a euthyroid state, that is the normal state. After this 18 to 20 months, we have a maintenance dose. The maintenance dose is of 5 to 20 milligram 8 hourly. Now, why is this? This is because to have normal levels of T3 and T4 and TSH. Now, propylthiouracil is also another drug. Now, propylthiouracil is being used in mothers who are lactating or who are pregnant. Now, pregnant or mothers, or they are lactating mothers. Now, what happens is it prevents the peripheral conversion of T3 into T4. Okay, the dosage that is given is 100 to 150 milligrams 8 hourly. Also, we can give some beta blockers like metoprolol, propranolol. Also, we can give potassium iodide or iodopodate sodium. Now coming on to the radioactive ablation. Now radioactive is also having some indications and contraindications. First of all, if the patient is more than 40 years of age. Also, if there is recurrence, if he or she is hypersensitive to the drugs. Okay. Also, if there is a risk of the thyrotoxicosis. Now it is contraindicated in first of all in the smoking patients, then in pregnant mothers and mothers who are desirous of having a child. Now the dosage that is given is 200 to 500 orally. Okay, now in this there is sometimes a small risk of having thyrotoxicosis, thyrotoxic crisis. So to prevent that, first we give the pre-treatment with drugs and then we refer to radiotherapy. Now in surgery, this is a very important part in general surgery as well. I'll explain it better in that video, but for here, just a small reference, we do subtotal thyroidectomy. Now what is subtotal thyroidectomy? In this, what happens is, suppose this is our thyroid. So what we do is we remove all the parts and we leave a small groove. Okay, we leave a small groove which helps in protecting the nerves that are present there. Basically RLN. Okay, it's the groove is called I think tracheobronchial groove. I don't remember perfectly, but yeah, so we leave a groove behind. We don't like it is near total, but it is not total thyroidectomy. So now this is indicated in patients who have large goiter, then who have frequent relapses. Also, if the patient is not being cured by the drugs. Also, if before surgery you need to have a euthyroid stage. Okay, now you will achieve this euthyroid stage by beta blockers as well as the antithyroid drugs. Now, also few weeks before surgery the drugs are stopped and we give Lugol's iodine. Now this is done, then we also have to, if the treatment, if it relapses, then we go on to another modalities. If we did radiotherapy and it relapsed, so we will consider giving drugs or surgery this way. Now this is the first objective. The second objective is that we see that there are many ophthalmic problems also happening, so we need to treat the ophthalmopathy. Now for ophthalmopathy, what we do is we either give artificial tears, or we give carboxy or methyl cellulose. It acts as a lubricant. Then we also give a corticosteroid, which is prednisolone 40 to 60 milligrams. Now this will decrease. Why are we giving corticosteroid? To reduce the retroorbital edema. Now another modality, we saw that there were skin problems as well. So the skin problems were as in the loss of hair, redness of palm. Okay, so for dermopathy, so for dermopathy we give local betamethasone. Betamethasone is also a corticosteroid, but it is topical. Also, we can give a triamnicolone injection. So this completes the hyperthyroidism. To sum up, it is basically a clinical state which is a huge amount of thyroid hormones being released. Okay, now it happens more in females. It will affect all the tissues that have thyroid receptors. Then the causes we have common causes: Graves' disease, multinodular toxic nodular goiter, then solitary nodule. In uncommon thyroiditis, factitious iodine induced, jod based off, it is called as then drug induced. In there we have pituitary and thyroid carcinoma. Now in the clinical features, first of all we have white palpebral pressure, staring look. Then we have exposure of the cornea. Then there is excessive watery eyes. Then goiter is diffuse tachycardia. Then we have exertional dyspnea, good pulse volume. Then menstrual insufficiency, impotence. Okay. Then muscular weakness, exaggerated tendon reflex, restlessness. Also, we can see that there might occur psychosis, also confusion, altered space, mental state. Then coming on to skin, then perspiration, clubbing of fingers, pretibial myxedema, and then redness of the palms. Now, Graves' disease, it is the most common thyroid disorder. Now, it has three components in the triad. First is P. P stands for pretibial myxedema. E, exophthalmos. D, diffuse goiter. Then, what is the etiopathogenesis? There are B cells and then there are plasma cells. These plasma cells, what they do is they release the antibodies. Now, these antibodies, they immobilize the antigen. Due to this, their immune system starts producing autoantibodies. Now, these autoantibodies are called as thyroid stimulating immunoglobulins. What they do is they mimic the action of TSH. So, they will basically they will go and insert themselves at TSH receptors. Now, what will happen is there will be an excessive amount of release of the thyroid hormones. So, what you will see is there will be an increase in the T3 and T4, but there will be a decrease in the TSH, but there will be an increase in the TSI. This is easy to understand if you understand the whole process. Now, coming on to the symptoms, as I mentioned before, all these signs you must remember. All right, Joffrey sign is when there is absence of wrinkles on the forehead. Mobius sign is eyeballs are not being able to they are not the patient is not being able to converge the eyeballs. Then Dabby dimple sign is basically when the patient uh, is not able to yeah, when the patient is doing lid retraction, but it is exposing the cornea. Then lid lag, when we are moving one finger around right and left, and the person is not able to coordinate with according to the movement, the speed of the movement. Diplopia, double vision, exposure keratitis or osteoporosis, and then pretibial myxedema. In investigation, as I mentioned earlier, this is easy. Now in drugs, remember two drugs: PC, so personal computer, propyl thiouracil, and carbimazole. Carbimazole is the first drug of choice. Propyl thiouracil is given in pregnant mothers and lactating mothers. Then radiotherapy, remember the dose is important. Then surgery, remember the name, subtotal thyroidectomy. Then ophthalmopathy, for that artificial tears, carboxymethylcellulose or prednisolone is given to reduce the edema. Then dermopathy, again corticosteroid and tramiconazole injection.